The temporal region includes the temporal and infratemporal fossae, superior and inferior to the zygomatic arc, respectively. The temporal fossa, in which the temporal muscle is located, is bounded by posteriorly and superiorly by the temporal lines, anteriorly by the frontal and zygomatic bones, laterally by the zygomatic arc, inferiorly by the infratemporal crest. The floor of the temporal fossa is formed by parts of the four bones that form the pterion, frontal, parietal, temporal, and greater wing of the sphenoid. The fan-shaped temporal muscle arises from the floor, and the overlying temporal fascia, which comprises the roof of the temporal fossa. This soft fascia covers the temporal muscle, extending to the superior temporal line. Inferiorly, the fascia split into two layers that attach to the superior margin of the zygomatic arc. The temporal fascia also tears the zygomatic arc superiorly when the powerful mesotere attaches to the inferior border of the arc, contracts, exerting a strong downward pull on the arc. The temporal fascia provides resistance. The infratemporal fossa is an irregular shaped space deep and inferior to the zygomatic arc, deep to the ramus of the mandible, and posterior to the maxilla. It communicates with the temporal fossa throughout the interval between deep to the zygomatic arc and superficial to the cranial bones. The boundaries of the infratemporal fossa. The boundaries are um, laterally ramus of the mandible, medially lateral pterygoid, anteriorly posterior aspect of the maxilla, posteriorly tympanic plate and the mastoid and styloid process of the temporal bone, superiorly, inferiorly, which is the infratemporal surface of the greater wing of the sphenoid bone, inferiorly, where the medial pterygoid muscle attaches to the mandible near its angle. Take a look in your atlas, the lateral view of the superficial dissection of the great muscles on the side of the skull. Take a look in your atlas, right? The lateral view, right, of this part. The contents of the infratemporal fossa are the inferior part of the temporal muscle, the lateral and medial pterygoid muscles, the maxillary artery, the pterygoid venous plexus, and the mandibular, inferior alveolar, lingua, buccal, and chorda tympani nerves and optic ganglia. The temporal muscles attach proximally to the temporal fossa and distally to the coronoid process and anterior border of the ramus of the mandible. The temporal muscle elevates the mandible, closes lower jaw. Its posterior fibers retrude, which means retract, the protruded mandible. The lateral pterygoid muscle, which has two heads of origin, passes posteriorly and its upper head attaches to the capsule and disc of the TMJ. The lower head attaches primarily to the pterygoid fovea at the condylar process, which is the neck of the mandible. The lateral pterygoid muscle protrudes the mandible, which means moving forward, to enable depression of the chin, which is produced in large part by gravity. The medial pterygoid muscle lies on the medial aspect of the ramus of the mandible. Its two heads embrace the inferior head of the lateral pterygoid and then unite. The medial pterygoid passes posteriorly and attaches to the medial surface of the mandible near its angle. The medial pterygoid elevates the mandible, closing the jaw. The maxillary artery, larger of the two terminal branches of the external carotid artery, arises posterior to the nape of the mandible, passes anteriorly deep to the nape of the mandibular condyle, first or mandibular part, passes superficial or deep to the lateral pterygoid muscle, second and pterygoid part. Disappears throughout the pterygomaxillary fissure to enter the infratemporal fossa, which is the third or pterygopalatine part. The maxillary artery is thus divided into three parts by the lateral pterygoid muscle. And the branches of the first or mandibular part of the maxillary artery are the deep auricular artery to the external acoustic meatus, anterior tympanic artery to the tympanic membrane, the middle meningeal artery to the dura mater and calvaria, the accessory meningeal arteries to the cranial cavity, inferior alveolar artery to the mandible, gingivae, and the branches of the second or pterygoid part of the maxillary arteries are deep temporal arteries, anterior and posterior, which supply the temporal muscle, and the pterygoid artery, which supplies the pterygoid muscle. The masseter artery, which supplies the deep surface of the masseter muscle, the buccal artery, which supplies the buccinator muscle. The branches of the third or pterygopalatine part of the maxillary artery are posterior superior alveolar dental artery, which supplies the maxillary molar and premolar teeth, the lining of the maxillary sinus, and the gingiva of the infraorbital arteries, which supplies the inferior iris apimax, the side of the nose, and the superior lip. Descending palatine artery, which supplies the maxillary gingiva palatine gland and the mucous membrane of the roof of the mouth. The artery of pterygoid canal, which supplies the superior part of the pharyngotympanic tube and the tympanic cavity. The pharyngeal artery, which supplies the roof of the pharynx, the sphenoidal sinus, and the inferior part of the pharyngotympanic tube. The sphenopalatine artery, the termination of the maxillary artery, which supplies the lateral nasal wall. The nasal septum and the adjacent paranasal sinuses. The pterygoid venous plexus is partly between the temporal and pterygoid muscles. The plexus has connection with the facial vein through the cavernous sinus. The mandibular nerve descends throughout the foramen ovale into the infratemporal fossa and divides into sensory and motor branches. The branches of CN5 are the auriculotemporal, inferior alveolar, lingual, and buccal nerves. Branches of the mandibular nerve also supply the four muscles of mastication, but not the buccinator, which is supplied by the facial nerve. The otic ganglion, which is the parasympathetic, is in the infratemporal fossa, just inferior to the foramen ovale, medial to the mandibular nerve, and posterior to the medial pterygoid muscle. Presynaptic parasympathetic fibers derive mainly from the glossopharyngeal nerve, synapsing in the otic ganglion. Postsynaptic parasympathetic fibers, which are secretory to the parotid gland, pass from the otic ganglion to this gland throughout the auriculotemporal nerve. The auriculotemporal nerve encircles the middle meningeal artery and divides into numerous branches. The largest of 5 passes posteriorly medial to the nape of the mandible and supplies sensory fibers to the auricular and temporal region. The auriculotemporal nerve also sends articular fibers to the TMG joint, and parasympathetic secretes motor fibers to the parotid gland. The inferior alveolar nerve enters the mandibular foramen and passes to the mandibular canal, forming the inferior dental plexus, which sends dental branches to all mandibular teeth on its side. Another branch of the plexus, the mental nerve, passes throughout the mental foramen and supplies the skin and mucous membrane of the lower lip, the skin of the chin, and the vestibular gingiva or the mandibular incisor teeth. The lingual nerve lies anterior to the inferior alveolar nerve. It is sensory to the anterior two-thirds of the tongue, the floor of the mouth, and the lingual gingiva. It enters the mouth between the medial pterygoid and the ramus of the mandible and passes anteriorly on the cover of the oral mucosa, just inferior to the third molar tooth. The coda tympanic nerve, a branch of CN7, carrying taste fibers from the anterior two-thirds of the tongue, joins the lingual nerve in the infratemporal fossa. The coda tympani also carries secretomotor fibers for the submandibular and sublingual salivary glands. The temporomandibular joint is modified hinge type of synovial joint. The articular surface involves either condyle of the mandible, the articular tubercle or the temporal bone, and the mandibular fossa. The articular capsule of the TMG is loose. The fibrous capsule attaches to the margin of the articular area of the temporal bone and around the neck of the mandible. The joint has two synovial membranes. The superior synovial membrane lines the fibrous capsule superior to the articular disc. The inferior synovial membrane lines the capsule inferior to the disc. The articular disc divides the joint into two separate compartments. The gliding movements of protrusion and retrusion, which is translation, occurs in the superior compartment. The hinge movement of depression and elevation occurs in the inferior compartment. The thick part of the articular capsule forms the intrinsic lateral ligament, temporomandibular ligament, which strengthens the TMJ laterally, and with the postglenoid tubercle acts to prevent posterior dislocation of joints. Two extrinsic ligaments and the lateral ligament connect the mandible to the cranium. The stylomandibular ligament naturally attaches in the fibrous capsule of the parotid gland, runs from the styloid process to the angle of the mandible. It does not contribute significantly to the strength of the joint. The stenomandibular ligament runs from the spine of the sphenoid to the lingua of the mandible. It is the primary passive support of the mandible throughout the tonus of the muscle of mastication. Usually bears the mandible weight. However, the ligament does serve as a spring hinge for the mandible, serving both as a fulcrum and as a check ligament for the movement of the mandible at the TMJ. Muscles or forces producing movements of the mandible at the TMJ are the depression, which opens the mouth, the gravity, which primes mover, the suprahyoid and infrahyoid muscles, taking consideration the protrusion must occur for all but minimal depression. The elevation, which closes the mouth, the temporal, the masseter, the medial pterygoid, the protrusion, which is protraction of chin, lateral pterygoid, which is prime mover. Right? Take a look in your atlas, the anterior view of the coronal section of the right TMJ. The masseter, which is the oblique and also superficial fibers, only secondary synergies. The medial pterygoid, secondary synergies, the retrusion, retraction of the chin, temporal, which is the middle oblique and posterior Merely horizontal fibers only prime movers. Masseter vertical deep fibers only secondary synergy. Lateral movement side to side, grinding and chewing. Retractors of same size, protruders of opposite sides. To enable more than a small amount of depression of the mandible, that is, to open the mouth wider than just to separate the upper and lower teeth. The head of the mandible and articular disc must move anteriorly on the articular surface until the head lies inferior to the articular tubercle. A movement which is also referred to as translation by dentists. If this anterior gliding occurs unilaterally, the head of the contralateral mandible rotates, which means pivot, on the inferior surface of the articular disc, permitting simple side-to-side chewing or grinding movement over a small range. During protrusion and retrusion of the mandible, the head and articular disc slide anteriorly and posteriorly on the articular surface of the temporal bone with both sides moving together. The MTJ movements are produced chiefly by the muscle of mastication. The temporal, the L temporalis, is a fan-shaped muscle with its wide part covering the temporal region and its narrow part attaching to the coronoid process of the mandible. The main action of this muscle is to elevate the mandible, closing the mouth and approximating the teeth. However, its middle oblique and posterior, which is nearly horizontal, paths constitute the major retractor of the mandible. The masseter, a quadrangular muscle, covers the lateral aspect of the ramus and coronoid process of the mandible. The main action of the masseter is to elevate the mandible and occlude the teeth for biting and chewing. The mid-pterygoid, a quadrilateral muscle, is fixed to the ramus of the mandible. Its two heads of origin embrace the inferior head of left pterygoid. The main action of the mid-pterygoid is to also elevate the mandible. The lateral pterygoid is of triangular shape. The base of the triangle is formed by the anterior attachment of the two heads, and its apex is formed by its posterior attachments to the capsular disc or TNK and to the neck of the mandible. The main action of the lateral pterygoid is protrusion and translation of moving to jump forward. Generally, the expression of the mandible is produced by gravity. The suprahyoid and intrahyoid muscles, strap-like muscles on either side of the neck, are primarily used to raise and depress the hyoid bone or larynx respectively. This is relevant, for example, in the ability to also help to depress the mandible, especially when opening the mouth suddenly or against resistance. The oral region includes the oral cavity, which is the mouth, teeth, gingiva, which are known also as the tongue, palate, and the region of the palatine, tongue side. The oral cavity is where food is ingested and prepared for digestion in the stomach and small intestine. Food is chewed by the teeth and saliva from the salivary glands, facilitates the formation of a manageable food volume. The glutation, which is known as swallowing, is voluntarily initiated in the oral cavity. The voluntary phase of the process pushes the bowels from the oral cavity, preparing the expanded part of the digestive tract where the automatic phase of swallowing occurs. The oral cavity consists of two parts, the oral vestibule and the oral cavity proper. The oral cavity is associated with several functions, but the most pleasurable for most people are those associated with eating and drinking. It is in the oral cavity that food and drinks are tasted and savored. The oral vestibule is a slit-like space between the teeth and vocal gingiva and the lips and cheeks. The vestibule communicates with the exterior throughout the mouth. The size of this orifice is controlled by the circumoral muscles as the auricularis oris, the sphincter of the oral aperture. The buccinator, risorius, and depressors enervators of the lip, dilators of the aperture. The oral cavity proper is the space between the upper and lower dental arch. It is limited laterally and anteriorly by the maxillary and mandibular alveolar arches housing the teeth. The roof of the oral cavity is formed by the palate. Posteriorly, the oral cavity communicates with the oropharynx, which is the oral part of the pharynx. When the mouth is closed and at rest, the oral cavity is fully occupied by the tongue, the lip, cheeks, and gingiva. The lips, mobile muscular folds surrounding the mouth contain the auricularis oris, superior and inferior labial muscles, vessels, and nerves. The lips are covered externally by skin and internally by mucous membrane. The lips are used for grasping food, sucking liquids, clearing food from the labial vestibule, forming speech and articulation, which is the speaking. Examine the skin of the external aspect of the lip and the vermilion border that indicates the abrupt beginning of the transitional zone of the lip. The skin of the transitional zone is hairless and so thin that it appears red because of the underlying capillaries there. The upper lip lies between the nose and the orifice of the oral cavity. Laterally, the lips are separated from the cheeks by the nasolabial groove that extends from the nose and pass approximately 1 centimeter lateral to the angles of the mouth. These grooves are easier to observe when smiling. The upper lip has an intranasal depression, the piston, which is the lobe chart, that extends from the external nasal septum, separating the nostrils to the vermilion border. The lower lip lies between the mouth and the labiomental jaw, which separates the lower lip from the chin. The upper and lower lips are continuous at the angles of the mouth and are separated from the cheek by the nasolabial groove. The transitional zone of the lips ranges from brown to red, continuous into oral cavity where it is continuous with the mucous membrane. This membrane covers the intraoral vestibular part of the lips. The labial frenula artery is full of mucous membrane in the middle extending from the vestibular gingiva to the mucosa of the upper and lower lips. The one extending to the lower lip is smaller. Other smaller frenula sometimes appear laterally in a premolar vestibular region. The superior and inferior labial arteries, branches of the facial arteries, anastomose with each other in the lip to form an arterial ring. The pulse of these arteries can be palpated by grasping the upper or lower lip likely between the first two digits. The upper lip is supplied by superior labial branches of the facial and infraorbital arteries. The lower lip is supplied by inferior labial branches of the facial and mental arteries. The upper lip is supplied by the superior labial branches of the infraorbital nerve, and the lower lip is supplied by the inferior labial branches of the mental nerve. Lymph from the upper lip and lateral part of the lower lip passes primarily to the submandibular lymph node, whereas lymph from the medial part of the lower lip passes initially to the submental lymph node. Take a look at your atlas. The surface anatomy, the medial parts of the upper lip, right? The coronal section of the mouth region, right? And the cheeks form the lateral movable walls of the oral cavity and the zygomatic prominences of the cheeks over the zygomatic bone. The cheeks have essentially the same structure as the lips, with which they are continuous. The principal muscle of the cheek is the buccinator. Numerous small buccal glands lie between the mucous membrane and the buccinator. Superficial to the buccinator is an encapsulated collection of fat. This buccal fat pad is proportionately much larger in fact, presumably to reinforce the cheeks and keep them from collapsing during sucking. The lips and cheeks function as an oral sphincter that pushes food from the vestibule into the mouth proper. The tongue and buccinator work together to keep the food between the occipital surfaces of the molar teeth during chewing. The tonic contractions of the buccinator and especially of the auricular body provide a gentle but continuous resistance to the tendency of the teeth to chew in an outward direction. In the presence of a short upper lip or retractor that moves its force, crooked or protrusive teeth develop. The cheeks are supplied by buccal branches of the maxillary artery and innervated by buccal branch of the mandibular nerve. The gingivae are composed of fibrous tissue covered with mucous membrane. The gingiva proper is firmly attached to the alveolar processes of the jaw and the neck of the teeth. It is normally fixed, stiff, and keratinized. The alveolar mucosa is normally shiny, red, and non-keratinized. The lingual gingivae of the maxillary incisors and canine teeth are supplied by branches of the nasopalatine nerve and vessels. The lingual gingiva of the maxillary premolar and molar teeth are supplied by the greater palatine nerve and vessels. The mandibular, labial, and vocal gingiva related to the lips and cheeks of the mandibular incisors, canine, and premolar teeth are supplied by the branches of the inferior alveolar nerve and arteries. The vocal gingiva of the mandibular molar teeth are supplied by the vocal nerve. The lingual gingiva of all mandibular teeth are supplied by the lingual nerve and vessels. The teeth are hard conical structures set in the alveoli of the upper and lower jaw that are used in mastication and in assisting in articulation, size of teeth, and orientation in the jaw. A tooth is identified and described on the basis of whether it is its primary or secondary type of tooth and its proximity to the midline or front of the mouth. The surfaces of the tooth are described on the basis of the tooth orientation in the jaw. Children have 20 deciduous, which are known as primary or milk teeth. In each jaw on either side, the deciduous teeth and the usual ages of eruption are the medial and lateral incisors erupting at approximately 6 to 8 months respectively. One canine erupting at 10 months, two premolars erupting at 20 to 24 months. Its adults normally have 30 secondary teeth. In each jaw or either side, the permanent teeth and the usual ages of eruption are a medial and lateral incisors erupting at 7 to 8 when they reach their 7 to 8 birthday. One canine at their 10th birthday. The two premolars bicuspid erupting at the age of 9 to 11 years old. The three molars, the first and the second molar erupting at 6 years, and an early teen third molar, which are known as wisdom teeth, erupting during the late teens or early 20s. The types of teeth are identified by their characteristics. The incisors, thin, clean, age. The canine, single prominent hole. Premolars, bicuspids, two cups divided by a sagittal groove, and the molars, three or more curves. vestibular labial or vocal surface of each tube is directed outwardly or superficially, and the oral, lingual, or palatal surface is directed inwardly or deeply. The medial, which means proximal surface, is directed towards the median plane or the facial scope. Its distal surface is directed away from this plane. Both are contact surface, that is, surface that contact other teeth. The mastication surface is the occlusal surface. Let us take a break right here, and we'll be back in a moment. 1, 2, 3.